our next speaker, Dr. Gungor. I know everybody knows him, so he's talking on, for who, he's, yeah. He's a pediatric ENT surgeon here. He's an associate professor in the Department of ENT. So he's going to talk on airway and laser safety today. So,
good morning, everybody. My name is Anil Gungor. I'm lucky enough to work here at LSU, especially with the great physicians and nurses and personnel at the anesthesia department. I have had the warmest reception since I came, and I feel like part of the anesthesia faculty. The residents can attest to that because I do more IVs and intubations than they do sometimes. It's a very hard act to follow Dr. Borland. His talk was insightful, full of wisdom, wit. He's very articulate. He had a lot of facts. This talk's not gonna be like that. This is a straight surgeon's talk. Very few facts, lots of slides, lots of opinions, biases, basically surgically. Most of the things that are presented here are going to be well known to you, but I would like to give my special insight into how it is clinically relevant. I mean, we all know that the pediatric airway is very different from the adult airway, but what does that imply? What do we have to do differently, and how do we encounter problems that we don't encounter in adults, and how do we go about resolving them? So, why do we have another pediatric airway talk after Dr. Borland delivered this lecture? Because most of our codes are pediatric. Most of the respiratory distress are pediatric, 80% of them. Most of the cardiopulmonary arrests occur less than 1 year of age. So you will encounter these problems no matter where you go, what you do. And they're the largest class of injury, and they're more common in children than in adults. The pediatric airway is very prone to injury, and they're very difficult to fix. In fact, once the pediatric airway is injured, it takes me about a median of 3-4 years to fix it completely. And also, if you don't let me talk about the pediatric airway, like here I'm between jobs, I don't know what to do with myself. I go around poke monkey's ears, basically. So you have to keep me talking about this subject. My objectives here are to present the pediatric airway's unique features, some problem prevention techniques, and I'm hoping that we can arrive at better airway management practices. I'm hoping to contribute a little fraction of what Dr. Borland has contributed today. And I'm going to examine all these differences. There are about 12 key differences between pediatric and adult airways, and I'm going to talk about them. Some of them will be transitory, lumped together, but I try to answer and address each one separately. Now, we all know that the pediatric larynx is a lot higher. What that implies is that the tongue is right in your way. The epiglottis and the uvula almost form a continuum. That also makes kids up to age 3 years of age obligate nasal breathers. The larynx is very difficult to visualize, and during the induction phase, you have to use special positioning, airways, or special maneuvers to get the tongue out of your way. Here you can see that when you gag a pediatric patient, you can see the epiglottis come up and meet the uvula, whereas in the adult there's so much more space. It also makes the laryngeal structures very prone to injury if you use a incorrect size laryngeal blade. I see it with my residents when they're in training, and they first push the tongue away, put their laryngoscope blade in. They're in such a rush. They just lose themselves in the moment. They're so excited, and that's when the injury happens. They can go through the vallecula, they can injure and tear the epiglottis, the arytenoids, the vocal cords with an improperly sized or improperly inserted laryngoscope. Another difference is the slant of the vocal cords. In the adult, the vocal cords make a 90-degree angle with the thyroid cartilage. In the pediatric, up until 3-4 years of age, the cords slant downwards, making this angle between the cords and the anterior face of the thyroid cartilage less than 90 degrees, varying degrees. The clinical significance of that is in adults, your blind intubations, you're going to get away with them. They're going to succeed most of the time if you can manage to shove the tube somewhere in the midline. In the pediatric patient, everything is soft, the cords are slanted. More than likely, that tube is going to skip off and go into some other place. So it will easily redirect into the esophagus. So in kids, we do not attempt blind intubations. We always have to see the cords. Another key difference is the epiglottic shape. You all know about the omega shape, but what does that imply? During a dynamic exam, an omega shape is a lot more prone to collapse, especially given the softness of the cartilages, than a flat epiglottis. I use this to my advantage to treat a lot of laryngomalacia kids. I just trim the epiglottic ligaments that hold it down into an omega shape so that it will get a more anteverted and a more flattened posture. A few millimeters of airway will make about 50% improved airflow. So here you can see that during the beginning of the inspiration, everything looks good. If this were a paralyzed patient, you would think this airway is pretty normal. But mid-inspiration and end inspiration, you can see total collapse. I have seen epiglottis completely sucked between the cords and coming back. Ball valving, it can be that dramatic. In these kids, a Miller blade works a lot better than the Mac blade because the Miller blade has a smaller tip. You can actually keep the epiglottis out of your way, whereas the Mac blade is broader and more difficult to place. Also, the epiglottis is angled away from the trachea in the adult, but a lot closer, more retroverted in the pediatric patient. Another difference is the shape of the larynx. In the adult, we are dealing with a cylindric form. In the pediatric, it's more like funnel shaped up until age 3-4. That means that the narrowest part of the pediatric airway is the cricoid. So if you can get anything past the vocal cords in the adult, it will likely go past the rest of the airway. But in the pediatric, it's going to be the narrowest point. So you have to adjust your plans based on what size the cricoid is. The clinical implication of that is, one, you should be aware of that. In syndromic kids, you should pick one full size smaller endotracheal tube. But also, when you use uncuffed tubes in pediatrics, it will likely succeed because you can obtain a seal around the cricoid, whereas in the adult, even if you pick the right size tube, this area will be as wide or wider than the vocal cord, so you won't be able to get a good seal. That's why uncuffed tubes are successful in kids. So some anesthesiologists use uncuffed endotracheal tubes for kids less than 8 years of age, and they can get away with that because of this anatomy. The cricoid fully develops around 10 to 12 years of age. Up until that time, the relationship may hold true that the cricoid is the narrowest part. It also explains why croup is a pediatric problem, because the narrowest part of the airway is the only solid ring. That's where you're going to end up with problems when you have inflammation, edema. When I said try to get uncuffed tubes and fit them right, you may end up with a good seal. You have to be aware of the risk of injury, and there will be a slide later on that I will show. Another difference is the anatomical landmarks that you are used to palpate in the adult. In the adult, these are very easy to find, like the thyrohyoid membrane and the cricothyroid membrane and the hyoid bone. They're all funny in the kid. In the kid, the hyoid bone overlaps thyroid cartilage, so there is no thyrohyoid membrane to palpate. There is no thyroid notch to find. So all you're ending up is maybe a hyoid bone above here, and you can only palpate the cornea, or the cricoid, which is probably the least favorable place to get the surgical airway through, but you end up doing that. It's called a cricotomy. Another major difference is the kids have relatively larger occiput. So what helps in an adult for an intubation position, sniffing position, will not help, actually will be counterproductive in kids. You have to have a shoulder roll to account for the large occiput in the kid. You have a donut, you have to have an extension, not a flexion, no sniffing position in kids. And if you do not use head stabilization and your head is sort of turned, you will lose the symmetry of the anatomy. So I'm very obsessive about the patient positioning. You've seen me come and redo the tapes that you did. I'm not doing it to piss you off. I'm just doing it to obtain the symmetry that I'm used to it, because my brain works best with patterns that I can recognize. So I try to get everything anally coordinated so that I can show my best. Another difference is respiratory physiology. Kids are very, very different than adults. There is no surfactant before 35 weeks. Respiratory distress syndrome is very common. Kids' oxygen consumption is twice as high as the adults. The respiratory rate is very high. And they respond to any kind of challenge to their respiration by increasing the respiratory rate. They don't have any other tools. And exhaustion sets in very quickly in kids. So depending on when you see a kid during their respiratory distress episode, you may see completely different presentations. Early on, there is active labored breathing. They're trying everything to figure out how to breathe. Later on, they figure out. They lean forward, they're calm, they're auto-peeping themselves. And when you catch them at that stage, it's very hard to mistake that for anything else. Lean forward. If you stimulate them, they will lose their airway again. Later on, they will lose their airway noise. They will not be struggling anymore. They will lose their posture. That's the time when you should be running to the OR, because that kid's about to crash. So kids present differently for the same problem during different phases of their ordeal. They desaturate fast, hypoxia, apnea, and anesthesia. Their residual capacity rate based on alveolar minute ventilation is doubled. They lack type 1 muscle fibers around the alveoli, and their terminal saccules are about a tenth of the adult number. This equals around 10 years of age and older. So up to 10 years of age, pediatric lung is not fully matured. Small diameters make all the difference, and small diameters have a few details in them that will restrict flow. Here is smoke rising during a laminar flow phase, and here we introduce some turbulence and it stops flowing. Same thing happens in any tubular structure, air or fluid. Whatever turbulence you encounter will disrupt the flow disproportionately as compared to the size of the inducing problem. Another thing to remember is that the flow correlates to the fourth power of the diameter. However, there are other dynamics here. when your surface to lumen is high, then most of your flow will be in touch with the lumen. So that will also restrict your possible flow rate and will increase the effects of possible turbulence. We use this in our airway surgeries to our advantage. We try to make small changes in the areas where there's turbulence, and we have great effects. We have big results from that. Here you can see the effects of the force, power, and volume correlation. 1 millimeter of edema in an infant compared to an adult will cause more than 75% of reduction in flow, whereas in the adult it will probably go unnoticed. Another problem that we deal with in kids, which usually is resolved by the time they're adults, are unknown compression points on the airway. Kids are born with various anomalies or variations, and these can have major impact on their airway. For example, left pulmonary artery compression, right pulmonary artery compression, pulmonary artery sling, double aortic arch, and the most common one is aberrant innominate artery here. When we talk about traumatic intubation, this should be a movie. Yeah. Sorry about that, movie is not working. When we talk about traumatic intubation, we're not talking about a scratch. This movie was supposed to show you that the entire subglottic mucosa was avulsed and moving in and out as a flap. That was one traumatic intubation, one brief moment of a big sized tube introduced through the airway. The mistake was realized, tube was pulled back, but the mucosa was avulsed. And this is how it heals. When you have a circumferential scar injury, it will cause the lumen to obstruct very quickly, and these are very difficult to fix. I don't understand why my video is not working here. And then we have this. We have a tertiary referral center with the sickest kids, hooked on ventilators, circuits, all kinds of medical procedures are done, and the airway has to be established. It's a problem that needs to be addressed. The tube size has to be proper, the tube type has to be proper. And most of the institutions do not have an agreement on any of these issues. I have worked in 4 or 5 different institutions, and everywhere I went, they had a different opinion about these things. I think the best approach is to talk to whoever you're working with, your anesthesiologist, your NICU physician, the hospitalist, the ICU physician, to figure out what their impression, what their expectations are. Associated conditions make all the difference. You may use the same tube in a similar condition, but the associated morbidity is different, and you may end up with a complication, whereas you didn't end up with a complication in a different patient. Prolonged intubation, we still don't know how long is too long. In some institutions, I have seen 3-month intubated babies who had no airway problems, and I have seen kids who had severe airway stricture after a week of intubation. So again, it makes a difference in how things are done. This is a very common problem. If the patient's lungs aren't mature, you have to increase your pressure. If your seal is not perfect, you have to increase the pressure, and you have to synchronize it. You can't have the baby fighting the ventilator. I have seen that many times. Baby is improperly sedated, and every time the ventilator pumps in, baby tries to exhale, and that's going to create not micro trauma, it's going to create major macro trauma. You won't be able to extubate these babies. You have to be aware of self-extubations. We keep getting these consults from the ICUs saying, oh, will you please take care of this baby? This baby has self-extubated 6 times, and we can't extubate him by ourselves. In these instances, we don't start thinking, oh my, what a wonderfully strong baby, it self-extubates itself. We're thinking bad management. We're thinking this baby is not sedated properly, not the ventilation circuits aren't secured enough. We're just thinking this is bad management. Whenever there's a cough involved, you have to have a cough protocol in place. I've seen many babies where the cough was inflated for more than 24 hours because the shift changed and the nurse didn't know what to do, what to expect. The physician wasn't there. You have to have this protocol in place and obsessively followed. Otherwise, those babies will be your frequent flyers for subglottic stenosis. In training hospitals, we all have to learn, but during learning, we know we can cause damage, so we have to keep it to a minimum, especially surgeons. I think the best surgeon is measured by not what he can do, but by when he knows how to stop, when he knows not to operate. Continuity of care, dialogue is important, especially in ICUs when there's shift work. Every team that comes take care of the kid has to know the specific problems. I've seen many times when the night nurses came in and night doctors came in, the kid went for the worst just because of that. Well, the serious part of the talk is over. I'll take any questions. I wanted to show Dr. Borland how we enjoy crawfish here. Maybe we'll get him later on. But I want to show you this little girl that I met last year during a crawfish festival. She had a t-shirt that had crawfish on. So I said, do you know how to make a crawfish face? She was first very surprised. She didn't know. She tried and tried and tried and tried and got it right finally. That's her crawfish. So these are the differences that we talked about. High larynx, large tongue, slanted chords, epiglottic shape, laryngeal shape, large occiput, obscured landmarks, small diameter, poor support, immature lungs, limited response, and external compression. Yes, Dr.
Talk about the cough and the uncough tube. It's become somewhat controversial over some institutions with cough tubes, motivated kids, but sort of what the obvious issues are and sort of your thoughts.
Well, I like cuff tubes because many times when I do tonsil adenoids, I don't want anything to go past that tube into the lungs. But small babies, difficult airways, you can get away with an uncuffed tube if it's a bit of luck and experience to pick the proper size. If you pick too small a size and put the uncuffed tube in, you won't get the seal. But if you get it just right, the seal around the cricoid with an uncuffed tube may be just enough to get you through what you need. Again, there is no consensus. In Pittsburgh, they wouldn't use cuff tubes. And here, I'm just happy to see cuff tubes used, but again, I leave it to the anesthesiologist.
Was that at a certain age?
Up around 6, 7, 8, 6, 7.
Dr. Gunn, when you said cuff protocol, did you want them to deflate it for a while?
Exactly, yes. Yeah. There has to be a ledger, there has to be a chart where they inflate the cuff like 2 hours and then deflate it for 20 minutes, and that has to be followed throughout. The cuff can't stay inflated for long, and it depends on what kind of cuff there is, whether it's foam filled or liquid filled. Most of the endotracheal tubes and in their inserts, they have those cuff protocols that I've seen. But the most sensible way to address it is to not keep it inflated more than 2 hours at a time, and then at least 20 minutes of deflation. Yes, bless.
We're starting to use more and more high volume, low pressure cuffs, thinner cuffs that are balloon around the tubes. But because they're higher volume, you're starting to see a higher surface area of the trachea covered with the cuff itself. Is there any benefit really from the pediatric or like the smaller volume cuffs versus the higher?
Well, the smaller volume, the stiffer cuff, the more injury you can cause. When the pressure is distributed over a larger area, the injury is less. And we're talking about long-term intubations, not our 1 hour to 3 hour cases. I think low pressure cuffs, high volume cuffs are the way to go, but there are kits you can use it, and there are that you may not be able to fit it in.
So from our end, if it's going to possibly need prolonged intubation after surgery, perhaps the trainer using a high volume, low pressure cuff.
I would prefer to use those.
That's the initial intubation, so no need for exchange or anything like that.
Yes. Thank you.